Hey everyone, welcome to our video on benign biliary disease, primarily related to gallstone disease. And these are the primary disorders of the biliary system that we are going to be talking about. Starting, as you guys probably know by now on these videos, I like to look at everything in terms of different spectrums, usually of severity or intensity. And this is kind of a general sense of we've got biliary colic here at the top, fairly benign, and then we progress down to the more severe illnesses, ascending cholangitis and gallstone pancreatitis. And so to start, if we just think about the basic anatomy of the biliary system, that is going to explain the physiology of most of these gallstone-based diseases. So draw this out. This will be our liver. We've got a couple ducts coming down out of the liver. We have our our gallbladder sitting here under the liver and our cystic duct that's going to attach to the common hepatic duct. And then down here, extending with our common bile duct. At some point, it's going to meet with the pancreatic duct, and that's actually inside the pancreas. And then both of those ducts are going to come together and dump out here at the ampulla, and that, of course, empties into our duodenum. Of course, the duct right here would, of course, be going behind the duodenum. And so when we're thinking about stone disease, remember that we typically have gallstones forming here in the gallbladder. However, when they start to move, they can start to cause us all kinds of problems. And those problems can happen at pretty much any level of the biliary system or even into the intestines themselves. And so the first parts of this video, or for each specific disease process, we're going to be talking about the presentation, the pathophysiology, and the diagnosis. Then we're also going to touch very briefly on some management principles. And once again, we're talking about spectrums here. So in terms of severity and acuity of your problem, you can treat some things in the clinic or as an outpatient. These are usually non-urgent and not very severe. However, what you get exposed to most as a medical student and the more severe spectrums of disease are usually need to be treated in the inpatient setting. And when we're talking about inpatient, then diseases can either be urgent or emergent. And I want you to really be thinking about these things because I think this is the really big next step to make as either a medical student or an early resident is you're not just able to recognize and diagnose problems, but you're able to start thinking about how are we going to manage these? Is this something I can say, oh, follow up in clinic, we'll take care of it then? Or is this something more severe that needs to require a hospital admission and then maybe even urgent or emergent treatment? So I'll try to refer back to this spectrum as we go through each disease process. So our first disease we're going to talk about is biliary colic. And as you can recognize from the name, obviously we're talking about the biliary system, and then colic typically just refers to pain that comes and goes in waves. And this is a pretty common syndrome. We talk about colicky pain when we're talking about small bowel obstruction. So why does colicky pain happen? And the answer is typically related to obstruction. So in biliary colic, we have some of these gallstones in the gallbladder that temporarily come over here and plug up the cystic duct. And that by itself doesn't cause any pain. But what happens is your gallbladder periodically squeezes, most typically right after a big fatty meal. That's how this links into the typical presentation. So when you get this squeezing, now you have this fluid trying to make its way out into the cystic duct, but it's blocked by this stone. And during the duration of that squeeze, you have this compression, and that causes your temporary colicky pain. And then the key is and what differentiates it from some of your other presentations is when the squeezing stops and the gallbladder relaxes, this stone falls out, or just the lack of pressure means that the pain goes away. So when we think about presentation, this is typically that right upper quadrant pain that comes at a set amount of times after meals, maybe 30, 45 minutes, an hour. and is more exacerbated by fatty meals. And if we think about that, that all makes sense with this pathophysiology. The gallbladder tends to squeeze in response to fatty meals. It also tends to squeeze in response to any meal. So those stimuli make it more likely for you to experience that sort of quote unquote colicky pain. And it's not always pain. Sometimes patients can feel something a little bit more like indigestion or nausea and things like that. But this is the classic presentation, is that right upper quadrant pain right after eating. And now, so if we're thinking about managing this, remember our spectrum. So we've got clinic or the outpatient, or I'm just going to draw a symbol here, or the hospital. And the thing to remember with biliary colic is there's no infection. There's not even any inflammation, right? That's typically designated by the term itis, which we'll see later. So this is not an emergency. The patient should not be sick from this. They will be uncomfortable, but they're not sick. They're not going to die if they're not treated. They're not going to have a progressive infection. So they can usually be seen in the clinic, maybe follow up in clinic in a couple weeks, talk to a surgeon, and then get a surgery scheduled for a later date. Because obviously, if we take out the gallbladder, we take out all these stones, and you're no longer going to have any of these symptoms. So now moving up a little bit on the level of intensity, we have acute cholecystitis. Obviously, acute means acute, and cholecystitis means inflammation of the gallbladder. We're not going to really talk about chronic cholecystitis, but you can essentially think of that as being very similar to biliary colic and treated in a very similar fashion. But acute cholecystitis is a very different entity. So we go ahead and draw out our diagram here. Hopefully this is familiar to you by now. Hopefully my drawings will get a little bit better. So once again, acute cholecystitis, we typically have these gallstones sitting here in the gallbladder. And just like biliary colic, the gallbladder is going to squeeze, and one of these stones is going to get caught in the neck of the gallbladder. The problem here, though, is that when the gallbladder relaxes, the stone does not fall out. And now we have this constant obstruction right here. And the gallbladder is always secreting fluid. And so as that fluid secreted, the pressure is going to build up, and the gallbladder is going to swell and swell and swell and get distended. And in addition to causing that severe pain, it's also probably going to cause a secondary superinfection. And that's where the cholecystitis comes in. So there's pain and inflammation from this blockage causing swelling and an infection within that blocked lumen. And so how does this patient present? Well, frequently they'll have a history of biliary colic, that intermittent postprandial pain. But in this case, they might have pain just like they've always had before, but it doesn't go away. So it becomes a constant right upper quadrant pain that lasts. In addition, they will be getting ill. So they might have an increased temperature, a white count, vital signs, other vital signs changes like tachycardia, and they're going to be tender in the right upper quadrant on exam. We typically test this with what's called Murphy sign. We talked about that in our video on the abdominal physical exam. But what's key to remember here, as probably is indicated by the name, right? We have acute, we have itis, so we got some acute inflammation going on. Your patient's acutely ill. This is going to require more urgent management. So first of all, we've got an infection, so we're going to need to give antibiotics. And if they're a good operative candidate, they need to get their gallbladder out, and they need it out soon. So this patient does need to come into the hospital, usually to a surgery service, and get their gallbladder taken out sooner rather than later. So we're typically thinking an urgent cholecystectomy. And what do I mean by urgent as opposed to emergent? Well, unless this patient is dying, their blood pressure is dropping, they're having a really severe infection, then usually an urgent case can happen. And that's like, for example, if the patient comes in overnight, they can get antibiotics, they can get a little bit of fluid and wait until the morning and then go to the OR then when we have the full staff and everybody's gotten enough sleep. Now, if they're dying, they might have to come in and get an emergent cholecystectomy, but that is much less likely and much less common. And actually nowadays, rarely done because of IR and cholecystostomy tubes, which if you're familiar with those, just means they percutaneously place a tube into this. It's usually relatively easy for them because the gallbladder is big and distended. And then the drainage of the contents of the gallbladder will relieve that acute infection and allow for a cholecystectomy or removal of the gallbladder at a later date. And of course, if they do get surgical treatment, you just take out the gallbladder, just like we talked about in biliary colic, and their symptoms should go away. All right, and now moving a little bit beyond the gallbladder, we're going to talk about choledocholithiasis. Once again, we have my excellent rendition of a liver. I guess I was wrong about my drawings getting better. And we have a gallbladder here, goes to the cystic duct, and now I actually unintentionally drew this duct a little bit wider than normal, but we're going to roll with it because it works with this disease process. And so choledocolothiasis, lith meaning stone, choledoco meaning common bile duct, that just means a stone in the common bile duct. So once again, we typically have these stones in the gallbladder, but some of them manage to sneak through the cystic duct and come here into the common bile duct. And at some point in the duct, they got stuck. That's why we care. If they didn't get stuck, they'd probably just pass through and we would never know about them and we wouldn't care. But when they do get lodged here and obstruct, then we get a backup of bile into the ductal system as well as the liver. And so these patients, they typically also will present with right upper quadrant pain and pain that is continuous because this obstruction is not going away. But they will also have some laboratory abnormalities. And the key here is direct bilirubin. So you can imagine that if you have a stone in the duct and bile is backing up, that you're going to increase your total bilirubin, which is certainly the case. Then you want to go ahead and check that again by sending a direct bilirubin. And so if you have a direct hyperbilirubinemia, or if your direct bilirubin is elevated and it's as opposed to your indirect, that is a quite sensitive sign that you have an obstruction causing your jaundice or elevated bilirubin levels as opposed to something else, maybe hemolysis or something along those lines. So the patient will come in, like I said, they'll typically have this right upper quadrant pain. They'll have some abnormal, potentially LFTs. Like I said, bilirubin's the key one. They might have a slightly elevated ALT and AST, but they're typically not very dramatic. And that's just some inflammation of the liver from that back pressure or backflow of bile, but it shouldn't be a massive elevation without an increase in direct bilirubin. And now you can imagine that the patient's uncomfortable, their enzymes are looking strange. How does this patient need to be treated? And this patient does need to come into the hospital, and they actually need an urgent procedure as well, but this is not typically surgery. So as we've talked about before, anytime you obstruct a tube or obstruct a lumen, you cause an infection. And in this case, the area behind the obstruction is the bile ducts into the liver. The liver, of course, is an extremely important organ, and an infection in the liver can make you very sick very quickly. We're actually about to talk a lot about that in our next slide. So even if the patient is not showing signs of infection yet, excuse me, they need to come into the hospital and get an urgent ERCP. Now, there's some nuance to this. So even if their bilirubin is elevated right now, you don't know if that stone passed and maybe it's on the downtrend. So usually it won't happen overnight unless they're super sick. And you'll check some labs in the morning, see if the bilirubin continues to go up and then they need their duct cleared, or if the stone has potentially passed. But the other nuance to think about this is while they're in the hospital, we have to think about what caused their choledocolothiasis. And once again, the underlying cause is those stones over here in the gallbladder. So once their duct has been cleared, usually by gastroenterology doing an ERCP, then they should get their gallbladder out that same hospital stay. I call this an index cholecystectomy. It's not urgent, it's not emergent, but it should be done during their index hospitalization. So once the duct has been cleared, their enzymes are coming down and they're not having pain, usually the surgery service will remove their gallbladder at that time before they go home, just to make sure they're not lost to follow-up and to help prevent them from suffering some more severe complications. All right, and this is so highly related that I almost feel bad about drawing it again, but we're going to talk about ascending cholangitis. We have roughly the same picture as last time. This time I intentionally made the duct big. we've got stones here. They slipped into the common duct, and we have this obstruction. And this time we have the itis. So we have cholangitis, or an infection of the bile ducts, and it's ascending towards the liver. And this patient is sick. That's the key here. So they're coming in, they have fevers, they have an elevated white count, they're usually tachycardic, they might be hypotensive, and they have that right upper quadrant pain. We're not going to go into them, but it's probably a good time for you to review Charcot's triad and Raynaud's pentad, as those two are related to this disease. I find memorizing them to be somewhat silly, as it usually just, if you think through the symptoms of somebody who's sick related to their an infection of their bile ducts, it's just kind of common sense signs and symptoms. And then the Raynaud's pentad is just when they get that much sicker. But what I want you guys to be focusing on is, once again, the basic pathophysiology and then the management. So like we said, this has an infection, so we need antibiotics right away. This patient needs to be resuscitated with fluids, and this patient needs an emergent admission to the hospital and GI consultation for ERCP. I guess there's a little bit of nuance in that if you don't have GI or can't do ERCP, sometimes IR can do drainage from above, but the general answer is going to be ERCP for these patients. Once the stone is cleared, that inspection should begin to resolve. And depending on how sick they are and how early this is caught, usually they'll recover well, and then they should also get an index gallbladder removal or cholecystectomy before they leave the hospital, because this infection makes people really sick. They can die from this. You don't want this to recur, even if they did get their duct cleared and get a sphincterotomy and all of those things. So once again, ascending cholangitis, this should make you very worried. They present very similar to choledocholithiasis. They're sick. They have right upper quadrant pain. They also have that same elevated direct bilirubin. Their LFTs might be a little bit higher. But this patient needs to come into the hospital. They need to get an emergent ERCP to help treat this infection. And then before they are discharged, they should get their gallbladder out to prevent this from happening again. All right, and the last one, gallstone pancreatitis. Once again, gallbladder, gallstones, liver, duct. This time we're going to draw it all the way down where it joins with the pancreatic duct. This is a glorified pancreas, and then out into the duodenum here. So in this case, once again, same story. Ducts in the gallbladder slip through the cystic duct, enter the common bile duct. These ones make it all the way down here, and in some capacity get into the pancreas. And while they're in there, they irritate the pancreas. The pancreas doesn't take much to get irritated, and it takes a lot to cool it down afterwards. So something as seemingly benign as a gallstone coming down, pushing against things, can cause this inflammation to get started. Once again, as indicated by the itis in pancreatitis. Now, sometimes these patients can present with choledocholithiasis as well, which would mean the stone is stuck maybe somewhere in here. So it's stuck in a place where it can irritate the pancreas and cause that backflow. But the treatment of gallstone pancreatitis and choledocholithiasis, the treatment of choledocholithiasis is the same regardless of whether or not they have gallstone pancreatitis. So I'm not going to talk about that scenario. We'll assume that maybe the stone passed through. They're not still obstructed, but they do have this pancreatitis. So how do we know someone has pancreatitis? They have an elevated amylase and lipase. So anybody presenting with right upper quadrant pain, you're trying to figure it out, they should get an amylase and lipase and rule out that there is an aspect of pancreatitis to this problem. Now, typically this pain is more central as opposed to in the right upper quadrant, and it tends to bore through to the back or maybe even be present more in the back. But usually they also have some amount of right upper quadrant pain as well because they have this underlying gallstone disease. So that's a little bit less reliable. Make sure you check the amylase and lipase. In these patients, like any patient, can be on a spectrum of sick to not sick. The very sick patients, man, excuse me, the very sick patients are going to go to the ICU and get resuscitated and get very intensive care and probably have a long, rocky hospital course. But the people that just had a stone come through and pass and are looking okay, their amylase and lipase will probably go down pretty quickly when you check them day by day while they're in the hospital. If I hadn't said it before, then of course all these patients do need to be admitted to the hospital. If they have a component of choledocholithiasis, which remember just means that elevated direct bilirubin, sorry for my handwriting. If they have that elevated direct bilirubin, they do need an urgent or emergent ERCP. But if not, they just need to be followed every day in the hospital till their amylase and lipase go down, their pain starts getting better, and then they too, like everyone else, will need their gallbladder removed. And that should be, if possible, an index cholecystectomy before they leave that hospital admission. Once again, to prevent this potentially life-threatening complication from happening to them, either if they get lost to follow-up or just before their cholecystectomy happens. Now, if this patient is incredibly ill, they're in the ICU for weeks, usually the surgeon's not going to want to go in there until they've had several months to cool off. But in the short term, for most patients who are doing okay, index cholecystectomy is your answer. All right, so that should wrap it up. I think that took a little bit longer than I intended, but hopefully it was thorough and gave you all the information you needed. We walked through kind of from top to bottom through the biliary system, our various biliary diseases, and talked about their diagnosis and presentation, as well as some details on their management. Something I didn't talk about as much as I would like is the imaging for these diseases. Usually an ultrasound is what you're looking for at first. That can show you gallstones. It's non-invasive. There's no radiation. If there's cholecystitis, there will be the wall thickening and potentially pericholecystic fluid. And then when you're talking about the ductal obstructing diseases, it can show you if you have a dilated common bile duct. So a lot of really good information off just that simple, non-invasive, non-radioactive ultrasound. However, of course, a CT can also diagnose most of these problems as well. And that's it. These videos are for educational purposes only. They're not intended to diagnose or treat any diseases. Let us know if you have any questions or ideas for future videos in the comments, and we will talk to you next time.